Okay. Yes, as we were discussing our fecal microbiota transplant for today, aka giving someone crap, that's not what this talk is going to be about. What I'd like to do is just to go through and give you a lot of case scenarios on things that may be a review for many people, but especially in ambulatory care, things for providers to be aware of and be astute so that they don't miss some very important types of infections. Okay. So we'll go ahead with this. That's me, John Toney. That's what I do. And we'll go to the first thing. The objectives for today, as you see, is just looking at cases and trying to figure out from a small kind of a discussion and what kind of things do you need to think about with each one of these cases, which will involve not only, recognition of what's going on with them, but antibiotic management, and also in some of these cases, what would you do infection control wise? Is there something you should do, or is there not? Okay, the first one is an 18-year-old previously healthy college freshman who comes in to see you with 24 hours of fever, nausea, vomiting, headache, severe myalgias, and decreased ability to concentrate. On exam, he's febrile, he's tachycardic, tachypnic, and he's hypotensive. He's got a positive Brzezinski and Koenig sign, but nothing else focally going on. So what is a Brzezinski and Koenig sign? So those are things you look at to see if there's meningeal irritation, absolutely. So, he has that going on, and most notably also, and probably most concerningly, he's got a petechial rash that's progressing even while you're examining him. You see it's getting worse. Does that bother you? Yeah, because that's not normal. Things that are not normal might want to be concerning. And just a representation, obviously not this patient, but you see these little petechiae, and obviously if you're noticing more or if they're getting larger, that's really concerning. So he goes to the emergency department, and they get some stat labs on him, and he has a leukocytosis, also with a thrombocytopenia, and a coagulopathy. They do, as soon as they can, blood cultures and a lumbar puncture done, and obviously they would like for you to admit the patient. So he's going to the ICU because he's not doing well, and the ED nurse wants to know what kind of transmission precautions, if any, do you need for this condition? So those are the things that we need to just touch on. So what do you think, are any one of these the things that you would give or that you would recommend? So it's one of those, unfortunately, what do you think he has? And then how would you treat it? Fortunately, the days of trying to ask these double jeopardy kind of questions for the boards is uncommon anymore. They want you to know what's going on, and then they may ask multiple questions of which you've got to tick off several things. But in this case, what do you think's going on with this individual? Neisseria meningitis. Okay, so meningococcal meningitis. And so that's a concern, because can other people get that? Yeah, sure. He probably got it from a fair amount of contact with somebody who had this, was incubating it, he gets it, and unfortunately now has developed meningococcal meningitis. That's what it sounds like. So if that's what you think, which one of these would probably be the best thing to consider? So out of these, probably ceftriaxone would be the best choice. But at what dose? 1 gram a day? And so the thought here is, how good is the CSF penetration of ceftriaxone or of any antibiotic during a time of inflammation? When it's inflamed, it's better than when it's not inflamed. So with this, 1 gram's probably not enough. 2 grams is better, but realistically, we're thinking probably even a higher dose. Now you see, E is giving ceftriaxone at the recommended dose for meningococcal meningitis at 2 grams every 12 hours, and then adding vancomycin which is probably superfluous for this, but if you're not sure exactly what's going on with the patient and you think they're septic or something else going on, you could argue that Vanco would not be useful if this was even a ceftriaxone-resistant Neisseria, like we see with Neisseria gonorrhea. So really, the Vanc is not going to be used to treat this, but the dose you want of ceftriaxone is going to be 2 grams Q12. Okay, then what kind of infection control measures do you need to worry about with this individual? Droplet precautions? What about airborne? Now remember, airborne is things that hang in air, like TB, like measles. Things are really communicable that tend not to be in droplets. Now, if somebody is coughing and they're colonized in their oropharyngeal area, those are going to come out as droplets. Those are going to be like a 6-foot radius around that person, and then they're going to fall out pretty quickly, so it's droplets. So with that, they need to wear a mask. If it was airborne, they need to be in a negative pressure room, and you need to have an N95 mask or a PAPR to use while you're in there. So the good news with this is, we just talked about, it would be, realistically, droplet precautions. You don't really need contact. Airborne, we just mentioned, that's overkill. I mean, would that work? Yeah, sure, but it's really overkill. And we should always be doing standard precautions of doing good hand hygiene. So standard with droplet would be the best thing to do. And since we should always be doing standard precautions, this would just be added onto that. Okay, so just to remind you that it is Neisseria meningitidis. This is in a healthy patient who presents with a sepsis syndrome, meningeal symptoms and a rash. You treat as soon as that you think of that's what's going on, and if it's going to be a while before you can do an LP, give them the antibiotics. Don't wait in somebody who you think has meningitis to give them antibiotics. And if it was in an older person and you're thinking, well, maybe I have to wait for a CT scan to make sure they don't have something else going on, give the antibiotics up front. It's sometimes makes it a little bit more difficult to diagnose what's going on because now your cultures may or may not be affected. But it's better to try and figure out what's going on with a live patient than to say, oh yeah, well, we missed that and the patient's dead. So being reasonable about giving antibiotics as early as you can. You want to put them on droplet, as we talked about, and they need to stay there until 24 hours of therapy at least is going on, and they're improving. In this case, you have to watch out for Waterhouse-Friderichsen and people getting shocky in DIC, and there was a little concern of that with on the initial laboratories of worried about, are they unfortunately getting into a DIC. And then the other thing that's really important is to prophylax contacts. So that would be anybody that has more of a prolonged amount of, contact with the individual. If they were sitting in a crowded emergency department for 2 or 3 hours, that would be a problem. Now you have to see who is potentially at risk. And actually, this person, you probably would want to make sure that they also could get prophylaxed too. And what can we use for prophylaxis? Rifampin is the old gold standard. When I was in med school, we had a guy who came in who had optic nerve edema. So he came in and had a petechial rash, had meningeal signs, and I'm trying to look in his eye grounds to see, if this guy has papilledema or not. And he coughs in my face and in the resident's face. And I was told by a very well-known ID attending who I had at the time, I didn't need prophylaxis. The resident and I both peed orange for 3 days because this guy had absolutely proven Neisseria meningitis. So maybe it was overkill, but I think that's useful. The other thing you could potentially use is fluoroquinolones, because right now there's no resistance with Neisseria meningitidis to fluoroquinolones, although that is a potential concern for the future. Okay, new case. 40-year-old previously healthy man who comes into the ED, brought in by EMS on the best time ever, Christmas Eve. That's when you're working, you're thinking, oh great, this can't be good, because nobody wants to go into a healthcare facility on New Year's Eve, or on Christmas Eve, I'm sorry. His family had been with him over the holidays, was concerned about his 3-day history of fevers and altered mental status. No one else has been around him since he's been sick. He has no animal contact, nothing like that was sick. He's confused, he's febrile, he's tachycardic, but he has a normal blood pressure and oxygen saturation. He hasn't had signs of meningeal irritation or a rash or focal neurologic signs, but as you're just finishing up at your exam, he has a tonic-clonic seizure. That gets your attention. People usually don't do that. So, based on his presentation, what of these do you think is going on? Do you think he has septic bacterial meningitis, aseptic viral meningitis, West Nile virus encephalitis, Eastern equine encephalitis, or herpes simplex encephalitis? Which of these is more likely to give you that kind of a presentation of causing an encephalitic type of a picture with confusion, etc., and then having a seizure? Do you see that with bacterial meningitis? Nah, that's not the presentation. Aseptic viral meningitis, usually more confusion, no real meningeal signs per se, because that's why it would be, it's not so much of a meningitis, but maybe an encephalitis. West Nile, probably not. That's more of weakness. Yeah. Yes, a little wrong time of day. Although, maybe he just came from South America where it's summer, and who knows. Eastern equine, again, probably not, mosquito-borne. So that kind of leaves you with herpes simplex, and that's not an uncommon presentation for some people with acute herpes encephalitis. So what's the most important therapeutic intervention for this? And until you really know, then most people would say, I'd probably give them everything that's on that list, which if you're just not sure and somebody shows up and you really think they have a meningitis or something, yeah, I mean, we're kind of all guilty of way over treating until as you start figuring it out. So of these, the best thing that you could give him is going to be which one? I mean, do you think he has listeria and you're going to give him ampicillin? No, probably not. So the real concern here is giving him good stiff doses of acyclovir and watching his renal function. So anybody who's got a fever, headache, and ultramental status, it is something to consider. It does have a propensity to localize in the temporal lobes, and that's sometimes where you can see it. We've had a case many years ago of a guy who came in and had a seizure, and they get a CT scan of his head, was uncontrasted, nothing there, and he said, yeah, I just assume this guy get a contrasted MRI. And radiology said, but there's nothing there. I know, but he had a seizure, and I'm just worried. And on his FLAIR and T2, this guy lit up, with temporal lobe. So just because the CT doesn't show it in an uncontrasted CT, you might see it on another neuroimaging study. So realistically, the diagnostic test of choice is getting CSF and testing it for HSV-PCR. And early treatment does reduce morbidity and mortality, and the way to give it with these cases generally is going to be pretty high dose IV. And again, watching renal function. 30-year-old gentleman with type 1 diabetes comes in as primary care physician. He's had problems with his blood sugar over the past several days. He comes in with symptoms of polydipsia, polyphagia, and polyuria. He has the polys. What does that suggest? Yeah, he's not doing well with his diabetes, really not doing well. So all symptoms of poor control. So you check his blood sugar. He says it's been 200 to 300 milligrams per deciliter over the last several days, but today it's been above 500. And in the last 24, 48 hours, he's complained of chills, facial swelling, headache, and a purulent type of a nasal discharge. He is febrile, he looks uncomfortable, he's got facial swelling and sinus pain on palpation, and when you're looking in his nose, that sometimes we forget to do, just a quick look with nasal speculum, then you see a black eschar. His glucose in the office is above 500, so yeah, he's not doing well. So you just send him home with some amoxiclav, right? No, God no, don't do that. So you get ENT to see him, and ENT goes in and says, yeah, we should get a sample of this. So they do some debridement of his nose, And then, again, this is what are we thinking with this condition? Which of the following would be an appropriate antifungal choice? So that's assuming that you're thinking this is a fungus and not just a nosebleed, right, with a clot. Occasionally, you can see herpes zoster causing a blackened area in the nose, again, from inflammation and a clot. That's not what this is because the slide says fungal. So what fungi would we be thinking about in a diabetic who's acidotic? Sure, mucor. And this sounds more like it's going to be Rhinocerebral Mucormycosis. So of those, which one of these would probably be appropriate? And actually, you could argue there's a couple. So now you get a 50-50 chance of picking a correct one. Liposomal ampho would be certainly a choice, and you can get pretty high levels because it's liposomal. What's the other one that actually does have an FDA indication for mucor? Asuvaconazolium, of which is metabolized to the active drug asuvaconazole. We do see people ordering asuvaconazole and can't find it in the order set and going, where's the asuvaconazole? Well, because it's not the parent compound and it's there. Ketoconazole, probably not that good. Posaconazole might have some activity, but the problem with this is there's really no good head-to-head between even ampho and asuvaconazolium, but either one of those would be a potential. We do worry about diabetes and acidosis, looking at a rhinosinusitis due to mucor. Other places where that you can see this is other things that are associated with acidosis, and especially iron overload, because many bacteria and fungi like iron, and you give them lots of iron and they like to grow. So what else could give you an iron overload kind of a syndrome and an acidosis? That we're sitting in a lecture room in an area where they're doing a procedure because of this issue. We're sitting in a dialysis conference room. So in people who are, have chronic renal failure, who are getting iron overload. 6998, I don't know who that is. So those are the things, occasionally we saw one when I was a fellow at Tampa General a long time ago, was a guy who was a dialysis patient who ended up getting mucor. So as we mentioned, the only two things that are FDA approved to treat mucor is liposomal ampho and asuvaconazolium. There's no head-to-head trials of either of these to see if it's one better or the other. But the thing that, as I was taught, and pretty much most of the fellows at some point in time have been taught, is if you see someone with mucor, what do they need to be on? And the correct answer is the operating room table and getting antifungals. They really need debridement, and sometimes it is really debilitating type of surgery. I mean, it can be really extensive. This is a patient we had from a long time ago. He ended up at our sister VA hospital. The guy came in and had DKA, and they noticed that his eye did not look good. That got biopsied. His nasal turbinate was also that color. He had mucor, and the picture on the right is after his extensive debridement. You can see it is extremely disfiguring. There are other people who've lost both eyes and everything else, so this is a real problem in managing this. They treated him, they sent him over to see us, and he had a lesion still in his brain that was near his brainstem. And at that time, there was no stereotactic brain biopsies to figure out. And so the most likely thing was this was mucor. We ended up treating him with extremely high dose of amphotericin B deoxycholate. Fortunately, did not kill his kidneys, and I believe with that one, we actually, because the data was just not clear, arranged for him to get hyperbaric oxygen. And after several weeks, actually that lesion went away. He was presumed cured. He was released from the hospital. 3 months later, he shows back up at the sister VA with DKA and didn't survive. So unfortunately, it looked like that we saved him from mucor, but his underlying disease was pretty relentless. 20-year-old Previously healthy male comes into the ED with 7 days of fever, sore throat, and right-sided neck pain. He also started having a cough, and he feels short of breath in the ED. He's febrile. He has an erythematous pharynx with exudates. He has tenderness and swelling along his right jaw over his sternocleidomastoid muscle, and he has scattered rhonchi on examination. What's causing all this? Is it Epstein-Barr virus? Does he have mono? Doesn't sound like mono. Is it Streptococcus pneumoniae? Maybe. We've seen some pretty unusual presentations of strep pneumo, and one of our patients having a 10-day history of a cavitary pneumonia with a bronchopleural fistula, and it being strep pneumo. But that person had undiagnosed myeloma, so there was a risk factor for that. It doesn't sound like it with this. What about Archaeobacterium hemolyticum? A, what is Archaeobacterium hemolyticum? If you don't know, that's probably not the right choice. So, Fusobacterium necrophorum? Maybe. How about influenza A? Influenzas do that? Not to my knowledge. There may be some obscure case where influenza A caused complications, but that's not going to be the. So we're thinking maybe this is Fusobacterium. That's a chest x-ray, which is not a great chest x-ray, but if you kind of, as I used to tell some of my mentors, well, I think I can hallucinate some pulmonary nodularities in this. And you can see a couple in the lower areas, and a few, if you had this on your view screen, and this was an electronic image, you could adjust the contrast and you probably could see them better. So let's say he's got what looks like these pulmonary nodules, he's coughing, he's got tenderness along his sternocleidomastoid muscle. What's going on with that? We thought it might be Fusobacterium, and then what's the next step in management? Does he need that vein, which we think might be involved with this infection, resected? Do we give him IV Amsulbactam? Of course, the answer now is no, because it's not available. So could you argue just giving him IV ampicillin, or you have to give him something else? What about high-dose IV penicillin? Maybe. Anticoagulation, does he need to be anticoagulated? Not at this point. What about giving him IV Vanco? Everybody needs IV Vanco, right? Probably not this case. So realistically, what he's got is suppurative jugular vein thrombosis or Lemierre syndrome. Usually they're due to either an oral infection, a tooth abscess, something else going on in the mouth, or an IV catheter, especially some that are placed in that area, venous jugular placement, something like that. Usually these are beta-lactamase resistant, or require a beta-lactamase resistant antibiotic, one that's got a beta-lactamase inhibitor involved, so using ampicillin sulbactam would be a really good choice. You could use something like piperacillin tazobactam, but that's way overkill probably, but if that's all you had. Or there are some other things you could consider. Carbapenems could work if there are shortages. So you do have some other choices, but the best would be narrow spectrum if possible. Vanco, for if you think it's an IV catheter and the catheter's infected, that's what's causing it, or MRSA, you could argue using that if it was catheter associated. Surgery if things don't get better on antibiotics, and especially anticoagulation if the clot seems like it's expanding. Then that's the time that you could consider that. I'd probably have surgery see them first and say, can we just do a thrombectomy? Is it an area where that you could surgically do that, and are you willing to do that? If not, then probably anticoagulate them so it doesn't get bigger. Just a graphic to kind of illustrate where the things can start, looking at tonsilary area with getting an infection and getting into the jugular vein, and this is really endotoxin from these bacteria that cause the clot. So stopping the infection, getting source control is the best thing. Just pictures as well showing you the neck vein, that this is not somebody pushing on their liver, and this is a patajugular reflux. This is a clot in that vein, and many times it'll be erythematous because of the inflammation, and a different x-ray looking at septic emboli due to Lemierre syndrome. Different case. 18-year-old female comes into urgent care complaining of a sore throat, odynophagia, difficulties clearing secretions. She says she's been spitting into a bag because she just really having increasing trouble swallowing. Hoarseness and fevers. Her temp's 38, so it's 100.4. Her heart rate's 100, blood pressure's 90/60, respiratory rate's 20. Not knowing her prior blood pressure, that might be a little concerning at 90/60, but she's 18 years old, so don't know. She's got erythema in the oropharynx with tenderness in the neck and pooled secretions when you're looking in her throat. She's only able to take small sips of water. So how do you want to manage this patient? This is actually a real patient. I didn't see this one, but a colleague of mine did. Actually, he was involved with the care after, and we'll talk about how he was involved after this. But do you admit him into the hospital for observation? You refer to the ED for immediate ENT evaluation? Do you send him home with a lidocaine gargle? Do you give him empiric antibiotics or to test for strep throat? Does strep throat cause you to have these kind of symptoms? Probably not, so we can strike that one off. What about prescribing empiric antibiotics? Empiric to treat what? So you'd have to, what does that mean and what are we treating? Do you send them home with just a lidocaine gargle? Yeah, that's going to numb your whole throat up, and if you have a problem swallowing then, you're really going to have problems swallowing. Probably not the best idea if you don't know what's going on. Do you send them in for an ENT evaluation? Probably not a bad idea. Is there something really bad going on there? It's a young person having trouble swallowing, really sore throat, or you just admit them for observation. You could argue one or two. You know, I mean, it's just dependent if you can get an ENT to see them rapidly, that would be the best. If not, they really should be admitted for obs, and then get an ENT person to see them. The other thing I would highly recommend is that you have a crash cart really close by. But they decided to send her home, not with a lidocaine gargle, with some empiric antibiotics, of which it was Keflex. Unfortunately died, and at autopsy had significant inflammation erythema of the epiglottis, and it grew Staph aureus. As a matter of fact, this one grew MRSA, so the Keflex didn't do anything. So that's an unusual cause of epiglottitis. We've historically been taught to think about H. flu. Now that we're giving, vaccinations for H. flu, it's become uncommon. However, that only covers H. flu B, and we are seeing some that are due to Haemophilus influenza that are the type O's, the untypables. Most of the H. flus do produce beta-lactamase, so if you're thinking about treating it, you might want to consider using a beta-lactamase inhibitor in combination with a beta-lactam antibiotic. So obviously I think most people know about epiglottitis, and if you see somebody coming in with that, they really need to be closely watched, or a lot of people will just empirically intubate them when it's a good time, because once this thing gets swollen, it is going to be horrible trying to get an ET tube in them. As we mentioned, usually due to H. flu type B, but also think about other streptococci and staphylococci as potential etiologies for this. Getting a good airway, obviously we keep harping on that because that's what keeps people alive. You can have all this infection going on, but if you can breathe, you live. If that gets shut off, you don't. And that's a real problem, because if that happened, they emergently need a trach. About the only way to keep people alive. Empiric antibiotics, if that's what you were thinking about and they're in a controlled situation, ceftriaxone, or if that wasn't available, or cefotaxime plus Vanco. If you're worried about MRSA, we can do rapid nasal PCRs now, looking to see if they're colonized with MRSA as kind of a surrogate and decide whether you want to do Vanc or not, or you can do Vanc and then stop it if the MRSA PCR is negative. This is a 28-year-old gentleman who has 3 days of worsening dyspnea, cough, and sudden onset of sharp left-sided chest pain. He's febrile, he's tachycardic, and they got an ECG on him that looks like this. First question, is this normal? A, yes. B, no. C, maybe. Get rid of C, it's not maybe. So it's a binary question. Is it or is it not? So everyone in this room is shaking their head back and forth in a horizontal thing suggesting no, it's not normal. It's not. Why is it not normal? What do you see? ST elevation. And where do you see it? Everywhere. It's like, where do you not see it? It's a better question. It's everywhere. So that tells you something's going on. So it's, again, what could be causing that globally? ST elevation. Everywhere. Pericarditis. Most common thing to think about, absolutely. So if you're thinking as pericarditis, which of these would be the best initial management? Do we give them TPA? Ooh, you could give them any of these you want. Which one's going to be helpful? That's not going to be really helpful. Do you whisk them off for a stat cardiac cath? If you're short of cash, I guess, but it's not going to help them. So that's not really going to be something in initial management. So then it comes down to these three other medications, ibuprofen, methylprednisolone, or colchicine. Which of those would probably be the best thing to give somebody who has acute pericarditis? Ibuprofen. Are you sure? Is that your final answer? Absolutely. Non-steroidals are really considered to be the drugs of first choice. Could you give them steroids? I guess you could if you didn't have any ibuprofen. If all the stores were out of any kind of, probably, but really ibuprofen is the drug of choice. Colchicine, no, probably not. Okay, what's the most common cause of his presentation? And do you think it's ischemic? No. Or else we'd have given him TPA, right? No. Is viral infection, bacterial infection, drug hypersensitivity? Well, there's no discussion of a drug, so that's probably not there. Collagen vascular disease. Sounded like he was doing fine. Didn't sound like he had an underlying comorbidity to cause this. So we're looking at either viral or bacterial. Which of those is more commonly associated with pericarditis? Viral. More often than not, it's going to be a viral. And it might be more than just a pericarditis. It could be a myopericarditis. So that's where you can see some of these post-viral myocarditis, people having problems because now the squeeze is not there. Their ejection fraction falls off, and then they come in symptomatic with what might sound like even an upper respiratory infection. So that's really what we're talking about is myopericarditis with acute ST segment elevations like you saw in that ECG, and it's diffuse. Initial management is with non-steroidals, viral infection, the most common cause, and with time, decreased ventricular function attributable to this. For most people now, especially with the newer, now I'm going to blank, medications that are available as far as, why am I blanking? The class of antihypertensives that one has available, including, now I'm going to only remember the brand name, Coreg. Carvedilol, thank you, sorry. That and ACE inhibitors and everything else gives you a much better chance of regaining cardiac function than with things we used to have in the past. It used to be a three-armed that people either did not do well and just didn't get better and didn't survive. Then there were people that kind of started to improve and plateaued and were unfortunately referred to in the past as cardiac cripples because that they were limited by their cardiac function. Or the third arm, which most people want to be in, is you regain everything pretty much and be close to where you were before you got this. And now using newer antihypertensives and looking at combinations, people do significantly better. And on top of that, some cardiac rehab too. This one you might know about because this one actually made the papers several years ago. A 7-year-old boy from California had been visiting in Switzerland with his family. He had gone through some airports, getting back, returned to the United States. January of 13th of 2008, he developed fever and a sore throat, January 21st, followed by a cough, coryza, and conjunctivitis. On January 24th, he developed a rash behind his ears and along his hairline over the next few days. The rash spread from his face, going down to his arms, the trunk, then over his thighs, lower legs, and feet. And that's kind of what it looked like. He got to the pediatrician's office. His temperature was 104. He did not look so hot. So what do you do next? And you see different things. Do you implement airborne precautions? Do you think he has TB? No. Why would you do airborne precautions? Is it trying to tell us something? Possibly so. Ask about an immunization history. Yeah, that would be a good idea too. And a 7-year-old who traveled to other countries. Could you draw blood for serology? You can. But again, we're trying to figure out what's going on with that. Serology would be useful really more for epidemiologic purposes with this. Do you give him vitamin A, 100,000 units daily for 2 days? You could do that. Is it going to change anything? No, but you could do that. What about calling public health? What would you like to call them? What are you going to discuss with them? What do you think is going on? And that's the question. So what gives you a rash in a 7-year-old who's traveled, and let's say that, yeah, we don't really think that we want to be using vaccinations the way that people are talking about. We think that, it's better just to get the real thing. So what could this be? Measles, absolutely, which we're currently dealing with, and it's a worldwide issue. So this is one of the early cases of measles that came back to the United States from a child, and there was a collateral, unfortunately a very publicly known collateral, who also got measles with this. So the incubation period, just to remind you, was around a couple of weeks, 10 to 14 days. It starts in the face, then goes to the arms and trunks, and then legs and feet. So it's kind of more, if you will, gravitationally pulled, my kind of way of thinking about it. It is extremely communicable. It's probably one of the most communicable diseases that we have. You really need to put people in airborne starting at 4 days before the rash appears. If you get someone who you think has been exposed, they probably should be kept away from other people that haven't been exposed, and you can stop airborne precautions when the rash has been present for 4 days, because they're usually already have an established thing, and they're not producing as much virus respiratory-wise and coughing. The other thing to look for is looking in the mouth at complex spots. Any of you ever seen complex spots? I'm old. I'll be 41 this year, maybe older. I've seen complex spots a couple times. I actually, when we went to India to do training over there many, many years ago, and it was at Ruby Hall Hospital in Pune, that they showed me a child who had subacute sclerosing panencephalitis. It was abysmal. This child was not going to make it. I mean, it's heartbreaking when you see that complication of measles. So complex spots you'll see on the buccal mucosa look like little white areas. Some people might confuse them with maybe small, little bit of patchy oral thrush. To me, it does not look like thrush. And that's kind of what you're looking at. Those are complex spots. There's little small dots on the buccal mucosa. That was the collateral, because that kid had been to Disney and had exposed some other kids while at Disney, and obviously this is a joke, photoshopped, but that was a concern with the first Disney outbreak. No, Mickey was not responsible for this. Moving on, 60-year-old diabetic female presents with urinary urgency, dysuria, and flank pain. Her symptoms started 3 days ago, but have intensified over the past 24 hours. She's febrile at 101, heart rate's 100, respiratory rate is 18, and blood pressure is 135/80. She's got tenderness to palpation at the costovertebral angle on the right. So what are you thinking of? 40-year-old diabetic lady, has urgency, dysuria, and flank pain, febrile. And you say, I don't know, show me the next slide, and then I'll tell you exactly. And you were correct, because you said you think that this is acute pyelo. You would be correct. Which of the following do you need to establish the diagnosis? an MRI of the abdomen, a contrast enhanced CT of the abdomen and pelvis, abdominal radiograph, an abdominal ultrasound, or nothing. If you own a radiology company, which of these do you think is necessary? Versus your practitioner, which of these do you really think you have to get to make a diagnosis of acute pyelo? You said, I just did. I used my hand. I tapped on their back. They didn't like it because it's uncomfortable. And they have everything else. This speaks of a urinary tract infection. We are now looking at it being an upper tract infection with pyelonephritis. So at this point, you don't really need anything. There was a really nice review paper, I think it was in New England Journal, looking at acute pyelonephritis last year. And a really nice review, and obviously the same kind of thing. But she's diabetic as well. Doesn't mean she needs a CT, but what is she more at risk for? That's a thing to think about, is emphysematous disease in diabetics. So emphysematous pyelonephritis, where you can see actually air inside the collecting ducts. Emphysematous cholecystitis occasionally, and emphysematous cystitis, where you can actually see air getting into the bladder wall and even in the gallbladder area. So just some things to think about associated with diabetes. So it's, going through this list, generally it's diabetes, usually not so much the other ones, obviously. So as we mentioned, you don't really need imaging to make the diagnosis. Diabetes and renal calculi increase the risk, as you know, with one of the consults recently of a very young guy who ends up with a stone in his ureter and gets pyelo from it. So it can have, if it's emphysematous pyelonephritis, increases mortality and should be really considered. If you do get imaging, you see gas in the renal parenchyma, that's a real key that you need to really watch this person, and they probably really do need to be in a hospital to manage this. A lot of acute pyelo and young people can be managed as an outpatient. The only reason that you'd need inpatient is if they can't swallow antibiotics or they're nauseated and vomiting. And so if they can't retain them, you're going to have to treat them with IV. That really needs IV treatment and needs close monitoring until they're better. Then you could consider de-escalating and sending them home and having them come back to see you in 2 or 3 days just to make sure they're doing okay. The other is to have urology see them to see if there is a problem. The other consideration with acute pyelo is if they don't deprivesce in around 72 to 96 hours, if it's not a decreasing fever curve or anything else, then they probably do need image to see if they have an intrarenal or perinephric abscess that you might have to consider draining to get source control. Okay, 24-year-old gentleman comes in several hours after an altercation in a bar. This was an intrapersonal argumentation. So he punched another person in the mouth. Now what are we talking about? A clenched fist injury. So he's got pain in his right hand. You're looking at the hand. He's afebrile. His vitals are fine. There are abrasions along his metacarpophalangeal joints on the right hand, and he has about a 0.5 millimeter laceration over his third MCP. There's minor swelling and pain with active motion. That area is open. So what's the best thing for you to do? Well, cleaning that wound and suturing it. Do you clean the wound and send him home without any therapy? Tell him to come back if he gets fever, drainage. Do you have general surgery, evaluate the wound, or do you start empiric antibiotics? Or you could pick more than one if you like. Or you send him home with a lidocaine gargle. No. Counsel him strongly not to hit people in the mouth. That would be a good one. But so which of these is probably the best? If there are any of those that you want to modify, you could do that. Like C, would you like to have someone else besides just general surgery see them? Would you want orthopedic surgery to see them if that's right over a knuckle and it's lacerated? And they're talking about swelling and things in their hand. Might not be a bad idea. Ortho may not want to do anything at that point, but just to say, let's watch this. I think, if you've got an open wound and it's been open for a while, you're probably not going to want to sew it shut. They usually leave those to heal by secondary intent. But obviously, yes, keeping it clean, and it's not unreasonable to start on some empiric antibiotics. Usually what we end up giving is amoxiclav because it treats a lot of oral bacteria. Obviously there's some that may not be affected by that. But if this is really, if you're thinking this could be a septic arthritis, now they got to come into hospital, and you're probably going to start them, at least front load them with some IV antibiotics. Human bites, as you know, are usually polymicrobial, and you probably, I would probably ask if they were available to have orthopedic surgery, see them, if not that day, the next day, just to make sure that this doesn't turn into a septic joint. But most human bite wounds should not be sutured closed because you're asking for a real problem. This is a 24-year-old gentleman with a history of sickle cell disease. Sees his primary care physician for headache and purulent nasal discharge. He's diagnosed with acute bacterial sinusitis. Give him a course of amoxicillin. 3 days later, he comes in to local ED complaining of intractable rigors, disorientation, sudden rise in temperature to 102.6. He's found to be hypotensive on arrival. What's the most common etiology? So let's just go back. A history of sickle cell disease. 24. He did get amoxicillin. He had, quote, acute bacterial sinusitis. At that time, when he came in, he had a headache and purulent nasal drainage. So now that apparently has not gotten any better. He's gotten worse. He's hypotensive on arrival. So what are we thinking about? What's going on with him that could predispose him to any of these things? So he has sickle cell disease. What happens with people who have especially recurrent sickle cell disease, sickle cell crisis? What are they at risk for besides bone pain and other things and infection? And what happens to their spleen, not uncommonly? Yeah, they infarct their spleen, they end up with functional asplenia. So now, if they don't have a functioning spleen, what are they more at risk for? Absolutely encapsulated organisms, and that's the key. Things that have a capsule around them. And out of this list, the thing that has capsules is going to be generally Streptococcus pneumoniae. Occasionally it gets them with recurrent treatment and resistance and encapsulated Pseudomonas, but that would be really uncommon. So we're worried about strep pneumo. And that's what we worry about is, you know, especially with sickle cell or post-splenectomy patients getting sepsis. And so besides strep pneumo, you'd think of Neisseria meningitidis, H flu, or other things that are more common things that asplenic patients tend to get exposed to. And you see the whole list of things there, lower respiratory tract infections that start after being kind of minor. And if it gets invasive, they're going to get sick quick. That's the thing you don't want it to get to is when they start getting petechiae, purpura, meningitis, and hypotension. But remember that at least for some of these things post-splenectomy, it's better if you can do it if it's going to be a planned splenectomy 2 weeks prior, giving them vaccinations for strep pneumo and also for H flu if they've never had it. It wouldn't be bad if you never knew if they did or not, just to go ahead and give them the vaccine. It's certainly not going to hurt them. So that's a wide variety of cases. I hope that it was helpful. Those are some things, obviously, if you're in an outpatient setting, you really don't want to miss. If you've got somebody who's, you're just not sure, they're in a gray zone, do I send them in to the ED or do I just follow them up, next day or so? Those are the ones that it's going to be your call and your thoughts as to they may need a little more in-depth evaluation, maybe, even an overnight stay someplace. So thanks for your attention, and we'll have to get busy getting everything else done as I keep getting paged. But thanks.